Okay. So now I'd like to introduce Michael Scott from Prostate Cancer International, who is our moderator this evening, to share with you more about the Prostate Cancer International organization and introduce our wonderful speaker this evening, Dr. Elisabeth Heath.
Thank you very much indeed, Jamie. So Prostate Cancer International is a relatively small prostate cancer advocacy and education organization. I do not have prostate cancer. I got into becoming a prostate cancer advocate by accident. You don't need the details, too complex. It's my pleasure this evening to introduce the very charming Dr. Elisabeth Heath, who works out of the Karamanos Cancer Center at Wayne State University in Detroit. She is not only an expert on the management of patients with very advanced disease, she is also a very dedicated researcher in this space as well. And since lots of things are changing very fast in the world of metastatic prostate cancer, we are delighted to have her here to speak this evening. So Dr. Heath, if you would care to go ahead and give your presentation, and after that I will grill you as badly as I can, and then we'll throw everything open to questions from the rest of the audience.
Thank you so much, Michael and Jamie. Thanks to Prostate Cancer International and cancer support community, and to all of you this evening. Thank you for joining us. You know, this is always a difficult topic in the sense that we doctors tend to make a complicated situation even more complicated and sometimes challenging to understand. So my charge tonight, as per Michael's request, is to really focus on a specific area in prostate cancer, which is really figuring out the treatment and just the workup and everything related to patients who are newly diagnosed metastatic. So just to put that into context, it doesn't mean that, you know, if you're attending tonight with a different type of stage of prostate cancer or anything else that you know, this won't be helpful. I think it's always helpful to educate yourself on the entire journey from a man's perspective. If there are caregivers on the webinar tonight, it's also important to know that you matter in this process. Many of our patients rely on caregivers or significant others as part of their treatment journey. And we want to make sure that whenever possible, if they're part of it and not attending tonight, to also share this meeting, because it's so important to get everybody on board. So just a little bit about me. I am a practicing medical oncologist and I specialize in genitourinary cancers. That translates to I see a lot of prostate cancer patients and hopefully try to help them. My job, honestly, is to make sure that I can explain what's going on and then come up with a reasonably clear treatment plan. Part of the excitement in prostate cancer is that there's just so much new knowledge that's emerging kind of almost all the time that even the experts, we're having a hard time keeping up. So I can only imagine how difficult it is for a person who's just trying to figure out what's happening to keep up. So yay to all of you for making the effort tonight, whether you're with us on this webinar or on Facebook. I think it's important that whatever you learn also gets shared with folks you know. The only way to really beat this is to educate one another. And I'm thrilled that Prostate Cancer International, along with so many other small and big organizations, recognize the value. So to keep us focused, our goal tonight is to, again, focus on patients who are metastatic, and we say hormone sensitive. That just means that you have not been on either hormone shots or what we call androgen deprivation. So this is a sort of a new step, and then to figure out what's the right treatment. But we're going to make this clear so that hopefully at the end of it, you've got some takeaways, because I give a lot of lectures, but honestly, if you can just remember one or two things from our discussion tonight, I would have done a good job to make sure that I educate. So we use this as doctors and researchers all the time. Those of you who have attended, I'm sure, the different lectures that Prostate Cancer International has put on recognize that part of the challenge is to keep straight where you are in this. So for those of, oh, can you guys hear me? Yeah. So for those of you who are just newly diagnosed or have been treated, you're in that clinically localized disease. For those of you who have had treatment but now are worried that your PSA is rising, that's your biochemical relapse. For those of you who have evidence of cancer outside of the prostate but haven't had treatment yet, fall into here. I'll also briefly touch on those of you who have been on either hormone shots or other forms of androgen deprivation therapy and have progressive PSA and where's the cancer? Don't know. So Michael asked me to also just touch base on that briefly. I think you'll have a more in-depth talk at a future time. And then I believe your next set of talks would be all these boxes in green in terms of, oh gosh, where are we with those? So where it gets confusing for all of you is a lot of the drugs that are here are also sometimes here and sometimes in trials here. So it is confusing. You have every right to be confused, but hopefully you can communicate with your doctor and figure out where you are. And you can ask, gee, where am I in the clinical states model? Or you can frame that as, gee, where am I in my patient journey? Sometimes you're just not sure. And you know when it happens, when somebody says, what stage are you again? And then you go, oh my gosh, I didn't ask my doctor anything. Number one question I get. So if you are having cancer outside of the prostate, that is a stage 4 cancer. So that's where we're going to focus on. But let me lead with this, which is that if you are having prostate cancer that's spread or trying to deal with it, make sure you know, because this is such a complicated and complex process, get your team together. Those of you who are all into football like my husband and is screaming at the television, you know it takes a team to make this go. And that team keeps expanding because boy, oh boy, our science keeps getting better and better, but it's also much more complex. So we have on our team in Detroit and many others similarly as well in the United States, pathology, clinical genetics, palliative and supportive care, physical therapy, nursing, social work, your primary care doctor, medical oncology, radiation oncology, urology, radiology, interventional radiology, occupational therapy, and the list goes on. And if you don't have your team, and it doesn't have to be that it's all in one location, I think, you know, it's a lot easy if you're at a university and you go, oh yeah, all my team members are here in one place. A lot of folks that I treat have different places where they have their teams put together. And there's nothing wrong with that as long as you can keep them straight and everyone can communicate. Communication in this day and age is the #1 challenge because everyone has different medical record system. Not all the notes are shared. Everyone struggles with trying to figure out, did my doctor communicate with my therapist who then needs to change my medication? And did that get communicated to my primary care doctor and so on? So get your team, make sure you know who they are. And better yet, put it on a piece of paper and share it with all your other team members so we are on the same team as you. Part of it also is when you get diagnosed, sometimes you get confused. Well, where is it? And I don't have a visual in my head once you tell me that it's stage 4 or metastatic. So let me just kind of put out here, what are the scans that you should be thinking about or that your doctor might ask for you to do? A bone scan is a test that uses a tracer called technetium-99. And it's been around for like hundreds of years. And I'm being a little bit overboard on that because it's one of those scans that drives us all bananas, including you guys. And why is that? Because this is sometimes the picture we see. Here's your skeleton and all these black dots kind of show that there's cancer there. Well, you know, that's all you know. You got the black dots. So what does that mean, doc? Well, those areas look like they may have cancer in there. Well, can you prove that to me? Not really, because I'm not going to go stick a needle in every one of those. But if you don't do this, sometimes you don't know where the cancer is. So if you're worried or the PSA is super high, your doctor's probably has ordered this scan. And then you got your standard CAT scan, which is, gee, is it in the liver? Is it in other vital organs? Is it in my lungs? So these two tests are very common. For those of you who are newly diagnosed or worried about recurrence locally, we're all doing MRI scans now of the prostate. It's become much more mainstream, no matter where you are, but it's also a scan that sometimes you have to ask for. So if there are problems or something local to your prostate or to your bladder, you might be able to advocate for yourself and say, hey, what do you think about an MRI of my prostate, doc? Because maybe that will help me decide what to do next, even if you have spread or metastatic disease. So I just wanted to put that out there. Okay, now here's all the good stuff that is confusing the heck out of everybody, which is PET scans. So all the rage that you guys keep hearing about is PSMA, PSMA. And I, saw a new patient last week who was like, I don't even know what PSMA stands for, but I'm on these support groups, and that's what all the seasoned men are talking about. And this poor guy was a little too embarrassed to ask. Let me just say, don't be embarrassed. You're in a place where if you're not able to ask your questions, then you're probably not in the right group. You should be able to be as open and forthcoming with your questions, because that group is for you. So I put this, not that there's a quiz at the end, but to show that this area of PET scans is really just changing. It's also a challenge to get prostate-specific membrane antigen PET scans because it's not technically approved US-wide. So you can ask your doctor. Everyone gets frustrated because it's not 100% like right in your next, town over, but it's also a discussion that you can have. So there are other types of PET scans, and knowing to even ask about them, I think really helps you better understand, gee, where's my cancer? And usually you ask, gee, where's my cancer? Because your PSA is not going in the right direction. The one that is approved, and I think many of you may be familiar with, is known as fluciclovine, or it goes by its trade name, Aximin. So the question here is, well, gee, Dr. Heath, you just talked about a bone scan and a CAT scan, and I'm going to be glowing here in a minute. Well, to tell you the truth, on an Aximin scan, we kind of want to see what else glows in you, because it really takes up cancer cells that move fast, as in it's trying to double and triple and quadruple itself, and then it picks up the tracer. So there is an approved use. Sometimes you say, well, I don't understand why my doctor won't get this for me. Sometimes you don't fit the indication. So just like anything else in life, you know that there are certain guidelines. So here are some of the guidelines. If you have worry after your surgery that, oh boy, maybe they didn't get it all, could we do one? Okay, yeah, that's actually an okay spot to consider. Or if you've had radiation, same issue. Or if you have spread disease. So what's it really look like? So here's a patient, fake patient, that basically has had surgery 2 years ago. And, gosh, I'm in follow-up and I should just be fine. But your PSA is going up and you say, gee, I thought my urologist said after surgery, I should be at a big fat 0. What am I doing with a 0.9 and then even a 1.1 and higher? So it's nerve-wracking, especially when you have no symptoms. You did the bone scan, you did the CAT scan. So now you end up doing the PET scan, and the big blue arrow tells me that, whoa, what's that doohickey right there? Well, that's a lymph node that decided to take up the tracer, which may be the culprit in terms of why that PSA is going up. So if you can find one of those, you might be able to radiate it. So here's an example of somebody who's thinking about getting that radiated. See how they traced it out. You zappity zap, you could decide whether the PSA goes down and maybe hopefully prevent any use of hormone therapy or something else down the road. Here's another example of a different patient who didn't have surgery but had radiation. So now you've had radiation and you're totally fine. And gosh, I had my PSA, bottom out at 1.2. And many of you on the webinar here know that when you get radiation, you still make PSA, right? You don't go all the way to 0 because you still have your prostate gland, which still makes PSA. But If you keep going up and up and up, there's still that same worry, uh-oh, it might still be there. So that same PET scan, you can see the arrows. You can't really see the lymph node on the left, which is your standard CAT scan, but on the right, you can see it glow here to say, oh, actually, those lymph nodes aren't big and fat, but they sure light up. So that's another sort of hint like, oh, maybe that's where it's hiding. When these things pop up, we worry that, oh boy, does this mean that this is turning into metastatic cancer? Well, that's the concern. So if we can nip it in the bud, I think we're making some headway. So that PSMA is just another type of PET scan, but it's very sensitive. So if you compare it, for example, to a bone scan where here's that same patient, doesn't show up anything, you do a PET scan, there's all those dots that you didn't see on this scan that you see on this scan. And sometimes we worry that that's really where the cancer is. So you can define that a person has spread or stage 4 or metastatic disease, really depends on the scans. So if you're not the advocate to say, well, gee, doc, you've never scanned me. My PSA is 4. I'm really getting worried. I had my prostate surgery. What's happening? So you can advocate for yourself to say, maybe you should talk about these and ask why or why not for these scans to be done. There's also other types of scans that we do, especially those related to bone health. So a lot of women, and if there are women on tonight's webinar will know about DEXA scans or bone density scans because they're used to worrying after menopause that you're going to get osteoporosis. Well, if you're getting treatment for metastatic cancer, sometimes we put you into that menopause, which means, oh no, it's coming down. Then we want to know if your bones are getting compromised. And it can get compromised because, you worry that all of that androgen deprivation or getting away that testosterone might thin out your bone. So in this same regard, you also can be quite proactive. Don't just take that laying down and say, oh yeah, I guess the cancer is in my bones. Make sure you look, because if you have thin bones, there's something to do about it. See, all these medicines are all approved. So you can have a question. And why do we worry? Because many of the patients are living longer and longer, which is wonderful, because years ago, maybe it was 3 years tops. We're now 5, 7, 9, 10 years. I have patients in my practice that are 12 years plus with stage 4. We keep getting better drugs. But you know what I don't want? I don't want fractures. I don't want cord compressions, which is when your spinal cord gets clipped, or broken bones that require surgery to help. So if we're advocating to make sure that we're getting what we need done, bones are a part of this discussion. So I want to make sure, again, thinking about this globally, it isn't just treatment, it's what else. So in the metastatic, I just got diagnosed, it's now spread cancer, bone health matters. The other part is a discussion about genetics. Now, I'm sure this has been touched upon in some form in this forum, but part of the new discussion points for metastatic prostate cancer patients is, I wonder if this stuff can be passed down to other family members. So it isn't just a conversation about family history, which, by the way, it's always a conversation about family history, but it might just be a conversation about, I have metastatic prostate cancer. Do I need to see a genetic counselor? Do I need genetic testing? And the answer is you do, and you do. Some places there's no access to genetic counseling, but when you get the test, there's a genetic counselor on the other end of that test to help. Sometimes you can reach out to the nearest large university that's around you if they don't have one in your local hospital, but you won't know if you don't advocate. So the second thing in figuring out how to best care for yourself or your loved one with spread or stage 4 hormone sensitive cancer is to make sure not just about bone health, but to ask about genetics. And we know this because all of a sudden, about 5, 6 years ago, we figured out that a lot of prostate cancer, especially as it advances, there's a lot of DNA that's compromised. There's a bunch of genes that don't work right. A lot of them hang out in the breast cancer gene area. So right now, people say, hang on a second, let's pull up a family tree. Yeah, I don't have any prostate cancer in my family, doc. I don't know what you're talking about. It's just breast cancer. Well, breast cancer, ovarian cancer, colon cancer, all of those can weigh into you as a man having prostate cancer, having the breast cancer gene or some other gene in that family of genes be positive. See, we never knew that 10 years ago. We had an inkling it wasn't right, but we never knew that. So at this point, about 10% of men, so that's 1 in 10 men who have metastatic cancer, might have something in their genetic makeup that could be passed on to other generations. To me, that knowledge is 100% critical and so important for you to advocate, not just for yourself to stay as up to date as possible, but to also have your loved ones in different generations be as educated as possible for themselves. So that's really important. There are other red flags of hereditary cancer. If you have greater than 2 close relatives with the same cancer, maybe. If your cancer happened early, so there are several of you or many of you or none of you, if you have cancer, let's say at 45, oh boy, that's usually a flag. Why is this bothering me? If you have 2 close relatives with related cancer, so several of my patients, well, I don't have prostate cancer in my family, but my sister had breast cancer, my mother had ovarian cancer, my auntie had colon cancer. Okay, that's enough for you to get a referral. The triple negative breast and all that, but prostate cancer has now joined this list. So as a newly diagnosed or not newly diagnosed, make sure you know this, because if the doctor, doesn't remember, or it just never sort of comes up in conversation, you can bring it up. So I hope that is, important and clear. We certainly can discuss that further at the end. But let's get to treatment options, because this is also really important, because all of the other more supportive measures are important, but it comes down to, what are you, doc, what are you going to do about my cancer? Well, it starts off with this androgen deprivation therapy. And you know what's hard, folks, on this webinar? The lingo, the language, how we just sometimes throw these terms around. If you don't understand what your provider or doctor is saying, just say, back up, I don't know what ADT is. Can you just explain that? So this means that you're either undergoing surgical or medical castration. Horrible terms, horrible. I run our advocacy group here in Detroit, and I've heard it for years and years. Our advocates hate the term castration. We say to them, oh, it's just a biological state, no testosterone, but it has complete lack of empathy or understanding of what the patient goes through. That's all of you. And it's a miserable term. So we've tried for years to get rid of it. Don't be offended with it. What you want to know is just to recognize that what androgen deprivation means is us taking away your testosterone, and the worry that perhaps that's not even enough in this certain situation. So when I first meet folks right at this point, this right here is sometimes gets glossed over, because this whole idea of me taking your testosterone away with treatment, whether it's a shot or it's pills, this is a game changer. This is a life-changing step. There's sexual dysfunction, a lot of symptoms like hot flashes and mood swings and irritability and sweating, weight gain. No man, actually no woman signs up for that. No person signs up for those symptoms. But these are things that have to be discussed. The piece that surrounds mental health is always poo-pooed. Oh, you're a guy, suck it up, you're all right. Let me tell you, I have seen it where this is so miserable that people just don't want the treatment anymore. So don't let it get to that point. There are a lot of treatments and strategies to help lessen the side effects, talk to your doctor. Don't stop at this point and just say, forget it. I always get this question, which is, okay, once you stick me on here, am I on this forever? Like forever, like years forever? Can I take a break? Why am I not done in a year? I'm always for data. I don't like to give 20,000 numbers. I can just tell you, here's the data that shows, yeah, we like to keep you on it, but we recognize that's because there's an improved survival. However, if you go on just on and off treatment, what's really important is your quality of life is better. So that's a discussion you got to have with your physician. If it's really miserable, then your quality of life is really important to put first, because that's not living when you're that miserable. If you're tolerating it okay, then I think most of us who would advise you, I think we would say, okay, I think you should probably keep going. So there is data to show this, and it's always important that whatever we recommend, there's some sort of importance, because having this is not something that's trivial. Because guess what, guys? You have other issues. And I say issues lightly because people don't come with just one diagnosis. Like, yep, I've got metastatic prostate cancer. There might be other things: high blood pressure, high cholesterol. You've got, you're maybe pre-diabetic or diabetic. Maybe you've had a heart attack. Maybe your sugars are hard to control. So with all of that going on, we recognize that having these injections or pills to lower your testosterone can add to this problem. So it's important to let your primary care doctor know this is going on, because we're doing this to you, but there's ways to fight against it. And many organizations, including ourselves, know that really improving your nutrition is critical. We actually offer, along with our medical students, a Fresh RX program, which really gives fresh fruits and vegetables to those living in Detroit to try to really improve their actual food intake. We have a CrossFit program we offer as a survivorship benefit. And yes, even though you're struggling with metastatic prostate cancer, you are a survivor and counted as a survivor. So whatever is in your neck of the woods, move. Figure out how to join a local YMCA. Figure out how to join a gym. Do it online if you have to. 20,000 exercise programs. I'm not saying you got to be like Rocky. I'm just saying you have to move. So it's really important to pay attention to that, because this concept of what we call metabolic syndrome is something that just creeps up. And next thing you know, you're so overweight that that makes you miserable. So this is something you can do. There's also folks who can take pills. So as the field changes, this is literally right hot off the presses from last year, which is we have an alternative to shots, and it's a pill called relugolix. And what's important there is that their side effects profile is a little bit better when it comes to cardiac and cholesterol. But this is worth discussing with your doctor, because this might be right for you. But if you're a person who's terrible at taking pills, it may be wrong for you. So don't make these decisions on your own. Just be aware that this is new, and maybe you should, ask your doctor about it. And the question also comes up with, well, gee, Dr. Heath, I only have like 3 areas on my ribs. I'm otherwise fine. Can't you just zappity zap those areas? And then maybe I don't have to go on these shots or these pills, so you take my testosterone away. Guess what? You're not the only one thinking that, because prostate cancer is so different one man to the other. If you have 20 areas that are affected versus 1, you're all considered stage 4. So what's important is to know right after you do all that imaging, where are you in that, tumor categorization? Well, it's really important that sometimes if you have very few areas of cancer, maybe to kind of hold off the whole ADT treatment and taking away your testosterone, maybe you can just treat locally. So sometimes it's radiation. In our shop, we like to freeze cancer. So sometimes if it's a lymph node, we'll freeze it with cryotherapy. some other organizations have used different forms of radiation, but either way, this ADT-free survival, what is that? Does that mean you're living? No, their endpoint is how long are you going to stall until you have to start that shot or that pill? Well, 21 months versus 13 months. So there's some value for, well, basically everyone, if you think this is something that you want to try, because you're not having any symptoms and there's just a low burden of cancer. So something to advocate for yourself. And this is the same thing, another study, because I always want to present things to you that have a backup, but this whole not just trying to stall the androgen deprivation therapy from starting, but also, looking at outcomes. So here's some outcomes of progression-free survival, terms that I know drive my patients crazy, but it's really just to show that there's some benefit. It's not for every person, but I think if you have a discussion about this with your doctor, it can at least be something that gets discussed front and center. The rest of it is mostly after you get your androgen deprivation, it's more of a question of what's next. Now, years ago, we didn't have that what's next. This whole what's next really started in 2017, 2018. Like that's brandy new in terms of the pills. But from chemo, it's kind of been around for a while. So 2004. So let me show you, these arrows point to the drugs that if you are just newly diagnosed and starting your androgen deprivation therapy, you should say, gee, what else should intensify my treatment? Chemo, docetaxel, Avaradarone, apalutamide, and Enzolutamide are all pills, and they're all hormone type pills. So they're not chemo pills, they're not biologics, they're not PSMA, they're not an antibody, they're not immunotherapy, but they're hormones. So you got 1 chemo and 3 hormones. And that's really important because this helps extend survival. Everything on this table that you don't need to know other than that, and that has all studies to back up why it works. They're all FDA approved. So it's not a study. And it's also really important to know that it's going to improve your survival compared to the person who is not on it. So that's critical. So let's just quickly run through that information. So here's the chemo, and I put this just as a reference. You don't need to really know it, other than it just shows that just with 6 treatments of this docetaxel chemo, that you do have a survival advantage of 15 months. Let me just clarify, that doesn't mean you are dead in 15 months. I'm that blunt about it because that's what people think, oh, it's a better 15 months. No, it's just that if you compare yourself to your neighbor who didn't get the chemo, you are going to have a benefit with the chemo of an additional 15 months. These are other trials that have been done in that same area. And it's also important to show that with chemo, it really works if you have a lot of cancer. So we call that high volume, but the definition, it's not, oh my gosh, I have 20 like I showed you on that bone scan. It just shows, well, I have 4 or more. So a lot of people might say, gee, 4 kind of, well, that's a small number, but that was just a cutoff on the study. Or if you have lung or liver metastases, so if the cancer went to those vital organs. So if it's high volume, I think a lot of doctors would say, listen, I think you better take the chemo because I'm kind of worried. So that's for docetaxel chemo. This is just information to support Avaradarone. So that might be a familiar drug to many on the webinar tonight, or it might be brandy new. If it's brandy new to you, go look it up. We put these names, tons of information if you just go to actually Google that name. But more importantly, I urge you not to Google. I mean, you can Google if you want to, but I urge you to actually talk to your doctor to say, hey, I heard about this drug. Is this right for me? And if not, when do you think it's going to be right for me, if ever? So it's just important to know it so you can advocate for yourself. these are the studies that show it really helps with survival. Anytime in oncology where I can see two curves separate and you can see it not just right up front in the class, but in the back as well, it shows some really good results. This is also another study to look at that apalutamide. So again, another curve where it separates out. And this actually was done in a good almost, 30 or 37% of men had low volume disease. So to show that the pills are actually pretty good with kind of all cancer. So a lot of my men will take either the apalutamide or another medication is enzolutamide that's also been around for a while. And what's really important is if you start to look at this, what you see is a pattern that the curves separate. As a patient and as a lay person, I don't expect you guys to know all of this because that makes no sense. In fact, what I could do is delete all of this and just show you all the curves to say, hey, guess what? This is why the FDA said it was okay, because it may help have people live longer. So if you look at why do people pick what they pick, what your discussion is going to be is, well, what's right for me? If I start on the ADT, again, whether it's a shot or pill, what's right for me is my second step. Because I just got diagnosed with cancer that spread, I want to be as aggressive as possible. So what do I need to know? And this is where your doctor should say, okay, well, chemo, after 6, you're kind of done. And you might have some of these side effects. Neuropathy, that's a big side effect. What does that mean? My hands and feet are tingling, kind of like when your feet falls asleep. You have that all the time, that might drive you bananas. And if you say, well, gosh, I have diabetes and I already have this, that might be then the wrong treatment because it makes your neuropathy worse because you already have it from diabetes. Your doctor might say, maybe chemo is not what we do. Hey, we got 3 other types of pills to consider. And Avaradarone is also another great option, but same thing. It kind of requires prednisone. So if you're a diabetic and your blood sugars are already no fun to control, maybe you don't like prednisone. In fact, your primary care physician definitely does not want you to be on prednisone. So maybe that's not the one that you pick. Maybe you're one of those folks who are kind of worried about rashes. So yeah, that's kind of a big deal with apalutamide if you're the one with the rash. We run the studies, we say, yeah, some people got rashes. If you're that person who has to go to work and, wear a suit and tie, although you wonder if that's still going on, but yes, if that's you, then, you may not be wanting to sit there with a rash so that your coworkers are looking at you. So you say, well, okay, maybe that's not for me. Maybe you consider enzalutamide, but you're so darn worried or you have a seizure history that you really don't want to try that. So all of this is really important because this is where options allow all of us to treat you with the best possible option for treatment, not just for the ADT, but to intensify it. So really important. Now, it's really interesting. When I just did these slides, oh gosh, 3 weeks ago. And the big question was, hey, I wonder if I give docetaxel chemo, do I need to pile on another pill? So yeah, it's really not something we know the answer to. And then in the meantime, just new reports came out to say, that might be the way to go because it's really showing some improvement in all of the endpoints we're looking at. So just in a few weeks, that is probably going to change. Now, is it going to change in active practice? Don't know. But is this a question that you want to ask your doctor? And why do you want to ask? Because here's the real life data. This is what's really happening. So we do all this work for trials. I got beautiful curves, whether you know what it means or not, you could see 2. So that's a win. But all of a sudden you say, well, hang on a second. Are we actually prescribing it? So just this year we looked, and it's called sort of a real world look, okay, you can look at databases that we all have access to say, what do the doctors in the US do? And the answer is not enough. So if you look at the Medicare database, less than a third of patients got that second drug. That's less than a third. This is treatment that makes you live longer. And for whatever reason, it was not offered. And if it was not offered, it was definitely less offered in Black versus white men. So another point of disparity. In another data set, half the patients didn't get the treatment intensification. In another data set, same, half the treatment, half the patients didn't get it, meaning in a group of 100 men who are eligible to get the ADT plus something else, 50 didn't get that something else. I just told you that all those curves separating shows that you live longer. So however this data is, we're not doing it right either. So I think to help fix the problem, we're doing a lot of education with doctors all around, but you guys can help because you're the community that it's happening to. So if you know that, well, hang on a second, I was listening to Dr. Heath on this webinar, and I think she said, I think we need to add something else. Isn't there something else? And let me tell you that breast cancer patients are top notch in asking those questions. What else, doctor? What else, doctor? And men, you guys tend to be a little bit shy or don't want to ask, or maybe really don't want to take it, which is okay, but you should ask. And the worst that'll be is like, nope, you're not appropriate to get it, or you've got too many things going on. But you should know as a patient why or why not you're not or you are taking it. I really hope that message comes through because I got to tell you, this data just came out this year, and man, oh man, were we bummed out to see that, because you're always thinking, oh gee, what do you mean? It's standard of care, we're going to do it, and it's not happening. So I want to just also touch about where patients are who have been on hormone shots for a while, but we can't see the cancer. So I want to pivot a little bit to say our previous discussion just now was all about newly diagnosed, not newly diagnosed prostate cancer, but sometimes it's newly diagnosed metastatic cancer. So you could have had it years ago, or you literally could have just been, this is your first diagnosis. Everybody falls into the same pot. Everybody's in this area. Sometimes you literally show up right here, or sometimes you've been here and dealt with this years ago, and so on and so on. But I want to talk about this space, which is a really weird space to be. And why that is, it's defined as, well, hang on, my PSA has been rising. You've been giving me these, androgen deprivation treatments, whether it's mostly at this point shots. And all of a sudden my PSA is going, we did the CAT scan, we did the MRI, we did the bone scan, we did the PET scan. You can't find the disease. I can't see the disease. Gosh, what's going on? Hey, my PSA is going up. So this is a really small group of you because most of the time our scans will pick it up. But do we worry that there's stuff there that we can't see? We're kind of worried, but sometimes we can't find it. And why do we care? Well, because you can't see it. Sometimes you don't know what you're treating. However, even in this space, we have treatment. So that same drug, that apalutamide, is also available in this treatment category. So let me just say again, one, it helps improve median metastasis-free survival. What does that mean? Just look at the 4-year number. You've been on the shots for 4 years, the overall survival, 70%, with the medication, 64%, with just placebo. Everyone is getting an androgen deprivation treatment. But if you look at it the other way, you have a 72% lower risk of metastasis or death compared to placebo. What does that mean? That means it's a win. And if you have it, you should be on it if you're able to. So I want to make sure that this funny little category where sometimes a lot of doctors will go, yeah, we can't, there's nothing to see, like there's nothing to see. So, come back again in 3 months or 6 months and we'll get you another shot and we'll see what happens. People feel, and they've showed me and has shared with me, it feels like they're a ticking time bomb, like just because you can't see it, that we're not treating. So here's one option. And, in terms of where we worry about here, in addition to the rash that we had talked about, and is blood pressure, but also that there's a higher rates of falls and fractures. And that's not to be trifled with. If you're an older man and you've got some balance issues, this might not be the drug, but that's okay, because good part is we have other options. So here's the second medicine called Enzolutamide. Does that sound familiar? Just like the apalutamide? Yep, they're the same drugs. It's just that it's the category that we put you in that makes it a little bit different. So don't get confused. The pills are the same. You're the same. It's just where you show up on the scans will dictate where you fit into that patient clinical disease model. So that's where sometimes people get super confused. They're like, well, I think I'm stage 4, but wait a minute, nobody knows. Am I stage 4 in this category? Because she can't prove where it is. So that's a funny spot, but just know that there's also this second treatment, and some of the side effects here is blood pressure, tiredness, and of course, a seizure history is probably not ideal to have that. And then the other one is another pill. So in this funny little space, you have 3 drugs that are approved by the FDA to be used. So the other one is darolutamide. They're all hormone pills. That's the first time I've mentioned this drug. Darolutamide is not approved in the folks who are showing metastatic disease. So if I scan you and it shows up, you say, oh, and I want to give darolutamide, the insurance will probably give you a hard time because it's not gotten an FDA approval. But here also a reduction in risk of death. So that's really important. And to know also some of this some of the problems here, is blood pressure and so on, but much more tolerated in all of the other aspects. But it's really only approved in this tiny little space. So let's review that, which is you're in this funny little space if you've been on the ADT treatment, if you don't see any cancer in all those imaging scans we talked about. The goal is to get your PSA to go back down so that we can breathe a little easier. And there are 3 choices: apalutamide, enzalutamide, and darolutamide. All 3 pills result in improvement in reduction of metastases or death. Pretty much all well tolerated with a little bit of nuance, so you can have some flexibility in your discussion with your doctor. And the really important part of this is to be empowered with the knowledge that even if you are in this space, you've got treatment options. So as a prostate cancer patient this is still considered metastasis, but it's a metastasis 0. So don't get bogged down in that. It's just that your PSA is going in the wrong direction and you're on these shots. Know that this is really available. So I want to make sure that all of you are aware that that clinical stage model is how your doctor thinks about you. So if you know how we think in clinic and in our practice, it helps you be able to communicate with us as well. Advocate for yourself on the imaging studies. There's a lot of, old stuff like bone scan and CAT scan, which is the tried and true. There's a whole slew of new ones with the PET scan. So don't forget about that. And honestly, if you have no idea what just got discussed and can't spit it back to your doctor, ask again, because sometimes it takes 2 or 3 times to get that messaging across. There are a lot of new FDA approvals coming out. They keep just growing and growing, which is great news, but it's sometimes hard to keep up. So one way is just to always communicate with your doctor, but sometimes it's to go on websites to educate yourselves. And there's a lot of them. So, doing this webinar for Prostate Cancer International is amazing. Asking the cancer support community for some help. Zero and Us Too have merged. So Zero, the End of Cancer, has a great website. American Cancer Society has a great website. All of this is critical. I can't advocate enough for getting the clinical trials up and running. We are trying to make sure that, when I give statements like this on webinars like this, that there's data and evidence to back it up. Otherwise, it's just, yeah, this makes sense because it's what Dr. Heath does. That's not what you want. You want, she does this because this is why, and be able to show you why. More is not always better. So in oncology, we like to pile on. Sometimes more is just more. So that's a discussion as well. Be aware that in the metastatic space, right when you get diagnosed, it's already in the indication to get genetic testing. Sometimes that means a visit to the genetic counselors. Sometimes that means your doctor will do testing and you really want to make sure you understand the results. There is a difference in checking testing for inherited issues as opposed to what's your cancer doing. Two separate tests, two separate discussions, two separate implications. If your doctor doesn't bring it up, say, hey, what about genetic testing for me? If you're worried because of COVID-19, please don't. By now, all health systems have figured out a way how to get you in safely and treat it. Every time we have a surge, no matter what state we're in, we sometimes will defer to telemedicine more. Whatever it is, it's really important. I have had some patients who, instead of an every monthly or every 3-month injections for their ADT, we sometimes go 4 or 6 months. Did you know we had yearly implants you can put in too if you're just worried about getting treatment? Talk to your doctor to figure out how we can suit you and address your concerns. Don't worry about getting locked into clinical trials. It's been really an eye-opener. A lot of companies now recognize, COVID puts a hamper on many things, so we'll be flexible with you on when you can and can't come in. I have patients who get COVID on clinical trials. We just keep on because it's important to continue to provide the best care possible. So I'm going to stop here, Michael and Jamie. Be happy to take any questions. I hope our discussion today was clear. I think my primary message is make sure you continue to build your team so they got all the right team members, and continue to communicate with your main team leader or team captain so that he or she can really help you to the best possible way for you. Thank you so much.
Thank you very much indeed, Dr. Heath. So I'm going to ask you just 3 questions as opposed to really barrage you. One is, on the team picture that you put up, I am assuming that you think that if the patient has any history of heart disease, their cardiologist is also one of those team members.
Absolutely. Absolutely. Yep. Great question.
Secondly, there is a lot of concern about whether if you start androgen deprivation earlier than you absolutely need, not absolutely, earlier than you really might need to, that it can actually stimulate the onset of castration-resistant disease. Would you comment on that?
Yeah, I honestly don't think that that's the case. And I also don't think that, saving it, like, well, I'm going to save it for when I really need it, works either. I think that the issue is more of what are you trying to achieve? And that's true for any treatment that's about to be started. It's always, what's the goal of the treatment and how long do I have to be on it and what's your expectation? The thing that we know that prostate cancer is addicted to is testosterone, period. We know it's complicated because there's a lot of things that make that cancer go. But the very first step is always to get rid of it. Now, there are some patients, honestly, that can't handle that. In my 18 years of being in Detroit, I have 3 patients that could not handle any form of androgen deprivation because it made their depression so severe, it required them to be hospitalized, and it was just not worth it. So I think that in terms of resistance, that's not the issue. I think that if it's something needed, you should ask, what are you hoping to do with it? And how long do you have to be on it to prove the point? So this happens a lot, Michael, in biochemical relapse. You know, it's like, okay, that PSA is going up, can't find it. I'm starting to really worry, you know, why is my level 4 when I don't have a prostate? Sometimes you pull the trigger and you say, fine, I'll take a shot or 2. But, you know, the hope is that it's reversible. And I think that's an important part of the story. When you're metastatic, though, the goal is to basically never let up, which is terrible for me to say and for you guys to sort of listen. But the goal is to not let up, because when you do, cancer sort of figures it out.
So my next question relates to PARP inhibitors. Obviously, they are only approved at the moment for the treatment of castration-resistant disease. But are you of the opinion that if you have had the appropriate genetic testing and it is clear that you have a BRCA2 mutation, or you have some form of other, you know, aberrant gene, that that is likely that we will be using PARP inhibitors sooner in the treatment paradigm?
Oh, yeah, I do. I think what's gonna, you know, inevitably happen is, like everything else in drug development, it goes from the, you know, oh gosh, things are so metastatic, to earlier disease. As you may or may not know, the PROPEL study was just reported of just combining, you know, the PARP inhibitor to the Avaradarone and showing some really interesting results. So it's probably going to happen. I think what's hard, though, especially in this category, is being on those medicines a long time. I'll tell you, the change that I've seen in 18 years, it's just people, thank goodness, are just living longer. So this is probably why I, you know, spaz out more to get that multidisciplinary team to be set, because as a survivor, you know, the worst thing I can say is, yay, Mr. Jones, great news. You know, your prostate cancer looks like it's in check. Sorry about your stroke. You know, that's not right. But the more drugs we have, the smarter we get. Folks are just living longer and longer. So we really have to be mindful, not just of our choices early on, but kind of like the sequence of what's the next step, and that's a challenge.
So my last question is, if I walked into your office tomorrow and I have a significant metastatic disease, it's under control on ADT, my bones are fine, would you today add an androgen receptor inhibitor to me? I mean, would you do that as a routine thing today?
I would, and you know, the hope is that it starts within 3 months of you starting your ADT. So what's always hard about data that happens down the road is, well, hang on a second now. I've been on this ADT for 2 years. You didn't know this. Am I going to pile on another medicine? In those instances, I don't, because I have no proof it's going to work. All these studies that I was showing you with all the lovely curves, you know, you start within 3 months. So that I can tell you, yep, if you start within 3 months, it's going to show a survival benefit. But if you don't, I can't tell you if you're just getting side effects or not. So that, I hope, is becoming, you know, fewer and fewer in numbers. But where we're seeing the struggle is it's not even being offered. So it's like, well, here's your shot. Thumbs up.
So
Yeah.
if I came in with those characteristics, and you're right, I've been on ADT for 2 years and it's well controlled, but I said to you, I want to have one of these drugs, I'm willing to take the risk it doesn't make a difference. Would that make a difference to your mindset?
No, well, I think it's more of willing to take the risk. I mean, nothing horrible will happen. It's just, I can't tell you if it will help. That's a different story of, and I hate to be a pessimist about it, but inevitably you'll get to that level where you're gonna need those pills because cancer is pretty darn smart. And then after a while, which might be 2 years or 3 years, it'll start waking up from its comatose state and go, wait a second, I've had this androgen deprivation shot forever now. Let me move on. So that's, for the person who doesn't move on, that's more of the exception as opposed to, what's more common. So what's more common is the cancer moves on, it wakes up and then says, I don't need androgen deprivation. At that point, then we would pile on the pills or do what else?
Okay, well, at this stage, let's throw this open to questions from the rest of the audience. And I think there may be some questions that have been given to CSC as well. And if we have a little more time, I'm sure I can think of some more.
Yes, we
Sure,
got several.
fire away.
We got several during your presentation. So the first is, what is the prevalence of tumor-specific and treatment-induced gene mutations compared with heredity? And how do these progress with extended and aggressive treatment?
Right, so great question. If you just look at inherited mutations, so let's say you do a germline test, which is what it's called, and you can do that either with blood or a cheek swab, and there's several vendors that do that. It's about 8 to 9% of men have an inherited gene that can be passed on. So you're going to say, well, what gene are we talking about here, doc? Okay, BRCA1, BRCA2, and ATM are the top 3 that usually that the counselors will tell you, you better let your other family members know what's happening. For the studies and for the folks who are not what we call germline, meaning not going to pass it on, you just want to know for everyone else, you're looking at about 20%. So instead of 1 in 10, it'll be 2 in 10 men that will have something in the BRCA1, 2, or ATM. But there are other family members in that same family that don't act right. So there are other genes, about 10 of them, give or take, depending on the study. But you have other genes like RAD50, PALB2, CDK12, RIP1, BARD1, all the ones that sound like, words that don't mean anything, but those types of different genes are flags that go, ooh, I guess I really should, worry about these. No, worry is not the right answer. In fact, sometimes your doctor would almost look overexcited. You're like, why are you so happy something is there in my profile? Because you feel like, oh gosh, I just expanded your treatment menu. Now there's something else that I can offer. The PARP inhibitor that Michael was talking about, all those drugs just try to tackle that particular group of folks. But I tell you what, guys, that's already changing with just that new data. I was saying, maybe you don't even need it. We don't know. But it's important to know that we make a distinction in our practice with something that is germline or inherited versus what's in your cancer. And I do that because I think it's important that you, as the patient, knows what are risks that will be sent down the line to the next generation and generations beyond versus stuff that's just yours. Hope that answers that question.
All right, great. Let's see. Our next question is, Dr. Heath, which would you say is a better treatment, EBR or proton? All other treatments are anchored in ADT, and I refuse ADT. Any hope for me?
Listen, the general answer is there's always hope. And you are not alone, because I've got lots of people who are like, get away from me with that. That is not worth living. No one's here to judge you. So my first request is don't fall out of the medical system just because you won't take ADT. I know sometimes you feel like, well, my doctor's not going to take care of me because that's what he or she has recommended. Complete garbage. This is your decision. We're here to support. So this happens sometimes when people want to do alternative therapy. So I say, listen, I'm here for you. If I can help, I'm happy to help. And I think if you don't have that right type of physician, then you might want to shop around because you're in this for the long haul. Now, the proton story has been around and continues to emerge. We actually do have a proton beam machine in Flint, Michigan. And there are certain instances where protons are extremely helpful. I'll tell you that I send my patients for proton, not so much for the primary prostate treatment, but for all those little doodads that show up on these PET scans. That sometimes you're like, ooh, that lymph node is really close to the bowel. I'm not that excited about it. Let's do proton. And in that case, it's been really targeted, minimal side effects, and great outcomes. So you're probably in that pot of, let's see if we can find out and do a whack-a-mole approach and find out what we can find out, treat what we can see, and then maybe we won't need to do that ADT forever or until later, whatever you decide. But that whole metastasis-directed therapy is a growing movement because there's a lot of men just like you who feel the same way.
So before we ask the next question, there's just something I'd like to emphasize that Dr. Heath just said. If you are not getting satisfactory answers to your questions from the doctors you're seeing, and Dr. Mowell said exactly the same thing earlier in this series of lectures, go find somebody else. These are always going to be your decisions, and you need the best help you can get to either implement them or be persuaded not to implement if they're a really bad idea. Thank you.
Absolutely. And also, if your doctor gets offended because you're looking around, that's a flag, honestly. I mean, I welcome people who want to learn more and just feel comfortable. So sometimes it does take a lot. Where I caution you is if you're doctor shopping or center shopping because you want the answer you want to hear, you're going to get stuck into a bad pattern and then nothing happens. And
that's true.
Yeah, so just to be as clear as possible, make sure you feel confident in your team captain. You have to. I mean, I outright admit I'm bossy as anything because I'm going to be your team captain and I'm going to micromanage each part because this is you that we're talking about. But it's also really important to recognize that the medical system is really built against us. And I'll tell you that we don't even have a portal. So talk about old school, we still got charts and it's a hybrid system. You just got to figure out what the system is and educate, to make sure that the expectations are there.
All right, great. Are you ready for the next one?
I'm ready.
All right. So what is the next treatment? Typically, if your PSA begins to rise after you've been on Lupron plus Zytiga, did I say that right?
Yeah. That's a great question. I'll tell you, it really depends on where you see the cancer. So there are folks who are having a lot of symptoms after the PSA goes up and you've been on this Avaradarone. And they just have, bad bone mets. Okay, well, radium is an option to consider. We don't think that another pill is the way to go. So sometimes you're like, well, but I've been on Avaradarone, shouldn't I switch to Enzolutamide? I could tell you that it's probably not a great idea because you won't last on that Enzolutamide. It's only good for 3 to 6 months because guess what? It's too similar in how it's trying to kill the cell. So the cell's like, wait a minute, it's the same, they're trying to get me the same way. So it just moves on. Some people will say, well, what about chemo? Yeah, chemo fits in that category. Chemo is highly effective when given appropriate and with really great care. It's a very tolerable step. It's only one drug every 3 weeks. So that's an option. But if I can and put in for a plug, the clinical trials is exactly in this group. This is the #1 clinical trials that's growing and growing and growing. And so there are a lot of new drugs out there to try to kill the cell. And what you want is access to that. So my advice to you is to say, okay, so before you give me the chemo, before you give me the radium, before you give me everything, do you have a trial for me? And if you don't, is there anywhere nearby that has a trial for me? So let me give you an example of a trial that we'll have up and running is with PSMA. So, is PSMA going to get approved anytime soon? Well, maybe. But even if you get it, am I going to have it tomorrow? Most likely not. So getting folks on trials is probably still the right way to go. I think here you should say also to your doctor, do I know my genetics? Did that get tested? Because remember, that's a really important part. Because if you have that breast cancer gene 1, 2, or ATM, or the other family members I was prattling off, then you might be eligible for a PARP inhibitor. And that's another pill that has been shown to help extend survival. That means longer life, as opposed to the other pill that's very similar to Avaradarone. So I hope that answers your question.
And I would add that this is a subject that we will be dealing with in next month's lectures with Dr. Ryan, which is an area he is very highly focused on.
All right, you may have just answered this question as part of the package for the last question, but what alternatives to Lupron are effective with fewer side effects?
Yeah, I think that's, what's hard is everything that is in that same class of drugs, you're getting rid of the testosterone. So they all have inevitably similar side effects of, the hot flashes and the sweating and the weight gain and the mood swings. But from a side effect profile of, hey, is my cardiac status and cholesterol and so on maybe better, that the drug is tolerated better, I would say that oral relugolix, which is the oral version of the androgen deprivation therapy, is showing up to be less in side effects for that situation. So I think it's really important to ask if that's an appropriate drug for you, especially if you have a lot of these comorbidities or medical conditions.
So Dr. Heath, some people swear by estramustine patches, and there's a trial going on in the UK related to that. Have you had any experience with that?
I have, there's, I don't want to say it's old school because that fits into, a lot of the treatments that some people may have had. I think we just have moved on from that because of all the other active agents. The same could be said for anti-fungal therapy like ketoconazole or itraconazole. So those, again, are pills that really try to reduce that whole sort of, testosterone path. So honestly, when I was in fellowship at Hopkins, that was all the rage. We gave everybody ketoconazole. But the mechanism is very similar to current drugs that are much more powerful. So we worry about, not so much because they're older drugs, it's just the side effect profile is still not zero with those compounds.
Thank you.
Okay, so we had a question. I had a recent Oxumin scan and showed a few hot lymph nodes. Based on a recent European study, I am recommended to have a 6-month ADT dose along with focused radiation above the prostate cavity. I already had salvage radiation in the prostate cavity. Any thoughts?
Yeah, I think it's a common approach. You could argue that if they could, I don't know if some of those nodes are in, the prostate area where it's been radiated, but anything above that is a very common place where I see my patients recur. So it's almost like, yep, you can draw the little line where they had their initial radiation and it sits right above it. I think radiating that has been an alternative. Sometimes this is where if it's in a tricky spot, as in it's close to organs and you're pretty worried about it, this is where I've sent my patients for proton so that it's really less scatter and in and out. So I certainly have recommended that for my patients as well.
Okay, great. Did you say that darolutamide, I gotta say that nice and slow, is or is not FDA approved?
It is.
And will Medicare pay for it?
Yep. So I can say all the drugs that I mentioned today have data and are all FDA approved. your insurance, that's a trickier question. I can just say that we sometimes fuss about it more in the state of Michigan because we're 1 out of 7 states that still don't have the oral chemotherapy parity law, which means that your insurance is not mandated to cover cancer treatment if it's a pill. So I don't know whether Tennessee or Kentucky or wherever you are has that same law, but we sometimes struggle with getting these fancy pills because they're so expensive. But there's always a way to get it. So even if somehow the insurance doesn't cover it and wants this and that, you have to have your doctor try to appeal. So we appeal all the time, like, well, I'm picking this one over this one because, and if you can justify why you're doing it, usually they come back and go, okay. I think a lot of times they just figured we're too busy, and not me. I love torturing everyone. So I'm like, well, I really think this is what I would like. So here's the paper. Here's all the doodads. And I think they see that packet with, 20 attachments. They're like, we're just going to approve that.
Clearly, if you're having your problem with your insurance company, you should go up to Michigan and see see Dr. Heath. He'll solve your problem.
I can also say that what also is important is, sometimes they'll say like, oh gosh, because, darolutamide might be anywhere from, 12 to 15,000 a month, depending on where you are and what insurance you have. But most places around the country, if there is some additional coverage needed or a grant mechanism, it can happen from patient advocacy funds or patient funds. So there's usually grants that's able to cover that. Some people don't know that, so I'm sharing that with you because that's usually the next question to ask is, so that's great, is there a patient fund? And those patient funds are national. So there are some that are local, but most of them, like PNAF and stuff, are national. So you can ask your pharmacist or specialty pharmacy to work with them.
Great. And it looks like I just have one more in the chat box, and it's more of a statement, but the person commented, I get worried when I hear median overall survival being discussed with patients without reference to the statistical variation around this figure. Some men will do worse and some will do much better. No one can predict without any precision the outcome for an individual.
100%. I hate it too. In fact, all of it, OS, PFS, I mean, it's hard, but where I think it's important and where, honestly, as the Associate Center Director for Translational Science at my institute, it's not, I always kid around, I say, oh, it gives me license to harass everyone, whether you're a lab scientist or a clinician. But really, it's really this way to make sure that we can advocate for you as a patient and as a community so that we can translate this. You have to have statistical rigor to run the trials. So although it all seems kind of crazy and maybe you don't have the standard this and so on, for this type of clinical trial design and publication, there are a lot of steps to get it through where statistically speaking, it meets those endpoints. Now, that's a different thing to what's this mean for me? So when I say, here's the data, and it shows in this group of men that by doing this, there's this type of survival, and you can get into the nitty gritty, but usually at that point, my patient tunes out and goes, okay, I will live longer, don't know how long, but at least it's better than whatever was the alternative. Then from a patient level, it's just important for you to know that all of the steps in getting to this point are rigorous. So we don't just rely on the stats. It's the whole process.
Yeah, I think there are two different things that go on here, Dr. Heath. I mean, one is what the FDA is doing, which is saying when we approve a drug, the average benefit of taking this drug, if you have this particular condition, is greater, significantly greater than the average risk. In other words, it is, your chances of doing well are better than your chances of not doing well on the drug. But you're right, this can't be applied to individuals. I mean, some individuals who take these drugs die 3 days later after they've started the drug. It's just, that's life. There may be something else completely different that they die of. It may not be their prostate cancer. They may have a heart attack.
And remember, these are just cohorts of men. So what happens in real practice is we get a little loose, you know, we're like, well, so you've had these two, but we're going to go with this. Well, that's not exactly the group that was studied, but close enough-ish. So there's a lot of extrapolations and sort of like, well, this could be. So whoever made that statement is 100% right. I'm with you. You're a unique individual. These are just ideas of what could or can't happen. Don't know, may not happen to you. So I always start with, here's what happened to a whole bunch of men who are somewhat similar to you, which may have these side effects or may not. You may, you know, you might get the maximal effect, or this might be a complete bust in 3 months. Don't know.
So if that was our last question, do we have anybody who wishes to ask another question of Dr. Heath online or live? If we don't, I've got one more for her. So Dr. Heath, have you had any experience with lutetium-177 PSMA yet?
I have, you know, at our center, we were a site for the VISION trial. So we did have many, many patients who were treated at our center. So I feel quite comfortable with the medication, and really I'm looking forward to having that drug barrel through and let's get it rolling. And you know, it's another drug in our menu of treatments to be able to offer.
And my understanding is that this drug will initially only be approved for castration-resistant disease, but they are already doing trials in metastatic hormone-sensitive patients.
That's right. There's definitely trials in that in this space, but it will be an approval for castrate-resistant.
Right.
Yes, and only for PSMA-positive patients, I'm sure.
Right, which I think is 70% of roughly of the men who have metastatic disease.
Correct.
So Jamie, I'm going to hand this back to you. Dr. Heath, thank you very much for your time this evening. You've been so accommodating, and Jamie will close us down.
Thank you for having me.
So thank you everyone for your time this evening, and thank you again, Dr. Heath. As a reminder, please join us next month for our final presentation in the series. It will be on Wednesday, October 20th at 7 p.m., where Dr. Charles Ryan will discuss the workup of men with metastatic castration-resistant prostate cancer. Thank you all for joining us.